All right. Hi, everyone. Welcome back. Hope you got a chance to refuel with caffeine and anything else. That is helpful. And we're going to get started again with session 2 on this day 2. So we're continuing our, for the next hour and few minutes, our focus on the challenges of opioid use disorder in rural settings. And just because we may have still some folks joining us for this session that have not been in the earlier one today or yesterday, Nicole, could you just give us again a quick rundown on any housekeeping items for this session?
Yes, I'm happy to. So again, we have our chat function open for attendees to introduce themselves to one another or foster any conversation during the presentations. Both our speakers this session will present, and then we'll have a general Q&A discussion to follow. We ask that you share your questions in the Q&A box rather than the chat section. The Q&A is where Stacey will pull the questions from for our presenters. And the session is being recorded and will be posted to our website and YouTube channel after the sessions are done, and that will likely take place sometime next week. And if you're following us on Twitter, you can use our hashtag BCBH2020 for anything related to the conference.
Thank you. That was helpful. So as Nicole just said, a reminder that we welcome any and all questions, and please just pop them into the Q&A box that you see at the end of your screen. So our two presenters are Dr. Kelly Peck and Nicole Brunet. And I'm seeing that Kelly's having some difficulties logging in. So maybe I'm going to throw Nicole a total curveball here and ask if you're willing, if we could start off with you and then just reverse the order of these two presentations. It's a short session, this session 2. So if that all sounds all right, I'd like to introduce our next presenter. Dr. Brunet graduated from the University of New England College of Pharmacy in 2013, followed by a pharmacy residency at the William Jennings Bryan Dorn VA Medical Center in Columbia, South Carolina. And she also completed a psychiatric pharmacy residency at the Providence, Rhode Island VA Medical Center. Dr. Brunet then joined the VA Maine healthcare system as a clinical pharmacy specialist in mental health. And in that capacity, she provides medication management and education to patients enrolled in the SUD intensive outpatient program. She consults with providers on complex psychopharmacotherapy cases, precepts pharmacy residents, and functions as the internal facilitator for the implementation of telebuprenorphine prescribing, which is very exciting to me, especially. We're really excited and pleased to have Dr. Brunet here with us today. And the title of her presentation is Increasing Buprenorphine Access for Veterans with OUD in Rural Clinics Using Telemedicine. Nicole.
All right, thank you for that introduction. Let me share my screen here. All right. I just want to thank Dr. Higgins for giving me the opportunity to come talk to you today and kind of tell our story of how we're able to increase buprenorphine access for some of our more rural veterans. And I'll be speaking on behalf of the Veterans Education and Research Association of Northern New England. As far as disclosures, the project I'm talking about is a VA Quality Enhancement and Research Institute grant-funded project. Other than that, I have no other disclosures. I did want to talk a little bit about opioid statistics. I know we've seen a lot of these over the past couple days. The data on the slide here is the CDC data from 2016. And although it's not the most recent, it is important to this project because when we were writing the grant proposal, we actually were looking at this as our most recent data. Not too far off from where we're at now in 2018 data, but nationally, there's about a overdose per 100,000 persons, in Maine being nearly 50% greater than the national average, close to 29 persons per 100,000. And as we know, rates pretty much are highest in our rural areas, and this project would focus on 3 different clinics. We do have our main facility as well as several rural community-based outpatient clinics, or CBOCs is how I'll refer to them on. And most of them are lacking on-site prescribers for medication for opioid use disorder. We know that treating veterans will likely improve their underlying conditions, decrease mortality, and hopefully increase the likelihood of treatment follow-up. About VA Maine healthcare system, our main hospital is located in Augusta, Maine, which is the capital. You'll hear me refer to this as TOGUS, which we commonly call it. We serve over 42,500 veterans, and we have full-time CBOCs located at the following locations, and then we have 3 part-time clinics as well. And of all VA Maine healthcare system, the only area which is not considered rural is Portland. So the majority of our healthcare system is considered rural. To show you this and give you a little more perspective on the Maine geography. So down here in the green circle is Augusta, that's our capital and where our main hospital is located. I also wanted to show you where our Bangor CBOC is located. This is important to the project because this CBOC already had an established buprenorphine prescribing program. They had groups implemented where they would require the patients to attend anywhere from weekly to monthly. And they had nursing on site that could really follow patients when they were doing the induction process, and they had rooms that the veteran could be in. So it is important to note where Bangor is as well. The 3 rural clinics that we focused on to increase buprenorphine access were Caribou, which is northern Maine, and it's about 4 hours to our main facility and 3 hours to the Bangor clinic. Then we have Calais, which is in down east Maine, so 3 hours to our main facility and close to 2 hours to Bangor. And then Lincoln. It's a little bit closer, under an hour to Bangor, but still quite a ride, quite a distance to be engaged in MOUD therapy. So in order to do this, we use that hub and spoke approach that has been talked about a few different times in this conference. So our hub site was actually physically located in Connecticut. So that is a telemental health hub that is funded by the VA Office of Rural Health. And they had existing providers and infrastructure already in place to provide care to our veterans located in our rural clinics. So the expectation of the hub site was that they would evaluate the patient, they would explain the treatment, obtain consent from the patient, prescribe the medication, provide follow-up to the patient, and provide ongoing support for the spoke sites. Our spoke sites were responsible for arranging the telehealth session for the patient, collecting the lab work and the urine drug screen, obtaining vital signs when the patient presented for an appointment, providing adjunctive counseling and medical care where they got their primary care on site. In order to implement this, the following methods were used. So like I mentioned, it was a grant-funded position. We had 2 psychiatrists with expertise in buprenorphine prescribing and a nurse serving as external facilitators. One of the psychiatrists, Dr. Mark Rosen, also an expert in implementation science. So their main role was to meet with our leadership staff, both at TOGUS and at the local CBOC sites, and really do that needs assessment and figure out what barriers we'd be facing and gaining that leadership interest on the local level for this project. I function as the internal facilitator since I'm physically located in Maine. My primary role here is actually a clinical pharmacy specialist. However, I did a lot of academic detailing, which is meeting individually with prescribers to change prescribing practices around opioids when the Opioid Safety Initiative was a big push for us. It continues to be, but in 2016, when the Maine law changed around prescribing opioids, we really had to get a fast support and make changes quickly. So I had some familiarity with the staff already at the CBOX because I had physically gone to visit with them, and they were just familiar with me from reaching out for help with any mental health pharmacy related issues. In addition to this, we did stakeholder assessment qualitative interviews because we really wanted to hear from the people that would be involved in this project on the local level, really what they thought about it and what their perceptions were. Some factors that favored the adoption of this program was really this underlying sense of duty that we heard from everybody when we were talking about this project, that there really is a need for MOUD, and people do want to help these patients get the care they need. Commonly would hear, people are dying. Everyone knows somebody who, not uncommon to know somebody who has passed away from an opioid overdose, had a friend who knows a friend. So everyone has this sense of duty to treat these patients. There's experience with the Opioid Safety Initiative. I touched on this a little bit, so I did academic detailing around that. The staff was pretty familiar with me on the local level, and additionally, very familiar with the opioid issues. Opioid overdose education and Narcan was another big initiative that we had starting in 2015 here. So the experience with opioid safety really moved this project along as well. We did have existing telehealth infrastructure locally. So because of our geographic location and distance from some of our bigger CBOX or our main facility, we really have relied on telehealth heavily all along. Some things that were important were pharmacy arrangements. So our VA pharmacy is located at Togus in Augusta. When we overnight a prescription to a place like Caribou or Calais, they say overnight, but that could actually mean 2 days. So having arrangements in place of what to do when you can't get a medication to a patient that day. We have what's called a nationwide voucher where the patient could go to a community pharmacy and get a short supply of a medication. And that's a widely used process in our VA system. Telehealth logistics pretty much worked out. We have a telehealth coordinator and several telehealth techs. And telehealth is accepted by both providers and patients. It's really been useful to get some of our rural veterans things like groups or subspecialty clinics that they wouldn't otherwise get. All right, some of our barriers to adoption at the hub. So in Connecticut, hiring of the telehealth prescribers. So we had the grant money to get the providers in, but just making sure you have the appropriate providers who are trained in addictions and would be the best choice for this. And they were helped by telework agreements, so allowing providers flexibility, working from home, doing this part-time really helped along getting appropriate prescribers. It seems to be a common theme in healthcare. Everyone feels overworked, spread too thin. The same with our IT department. So there was a little lag time waiting for them to add the new teleprescribers to existing service agreements between the hub and spoke sites. And then just the logistical things for the prescribers. Since they're physically located in Connecticut, not all of them had the opportunity to come up to Maine and meet with the local staff and really understand the different processes of how things get done. So a little bit of a learning curve initially. And making sure that they are registered or have delegates set up in the Maine prescription drug monitoring program so that they could check that every so often to check up on the fill history of medications the veteran was receiving. Barriers in Maine that I wanted to discuss were the understaffed CBOX. So we really saw staff turnover at every level during this project. We had a change in our chief of mental health during this time frame. We had a primary care provider at a CBOC retire and a new one come in, and we had nurses transition out of their local CBOC for other jobs at other sites. They also expressed a sense of feeling overworked, but this is another thing to add on to their to-do list. So really working with what was available and helping accommodate those needs. Tele-MOUD perceived as a primary responsibility of mental health. A very common theme that comes up. There seems to be this divide between primary care and mental health, sometimes about who's responsible for what. And since these CBOC sites only have primary care trained nursing and providers on site, we did get some pushback of, oh, this is a mental health issue. Why are you putting it on us? So really having those discussions that it's an issue that needs to involve everybody. It's the responsibility of everybody, and it shouldn't be a mental health primary care divide. Another barrier to consider was, will it undermine the existing buprenorphine program? So this was in reference to the program at the Bangor CBOC that was in place. They had a little bit more stringent requirements of the patient. They were required to go to group anywhere from weekly to monthly, depending on how far along they were in the program, which imagine if you live in Caribou, Maine, it takes you 3 hours to get there one way. That's pretty difficult to get enrolled in their program. They also did practice that 3 strikes you're out type approach. So we were worried that our program, being a little bit more lenient as far as prescribing buprenorphine in comparison, might undermine this existing program. Urine drug screens were a little bit of an issue as well. So the sample would be collected at the CBOC, but we relied on a courier to actually physically bring the sample to the lab at Togus and then be analyzed. So depending on when that was collected, there could be 1 to 2, even 3-day lag time before you're looking at the results. So being a little bit more reactive with things and proactive when it came to UDSs. So just keeping that in mind when you're prescribing to patients. I did include some of the comments that we heard during the qualitative interviews of staff, because I think it really highlights some of the barriers and facilitators I'm mentioning. So the first one here, it seems like a lengthy process for the veteran to get in, 1 to 4 weeks before they actually start getting Suboxone. So we know the best approach is really to get the veteran when they're motivated and they're showing up and wanting treatment. You're not losing that window of opportunity. And unfortunately, the Bangor clinic that was trying to provide a good service could be seen as kind of a barrier for the veteran of getting on Suboxone. Problems with the existing telehealth program. So I think probably just the biggest problem with telehealth would be the nursing support. If you're treating someone through telehealth, it's harder to assess people. There needs to be some education in Calais and the other rural Maine locations on these patients. They don't have mental health RNs, only primary care. So again, highlighting that theme of feeling like they don't have the appropriate support or training, and that divide between mental health and primary care responsibilities. These are perspectives from actual primary care prescribers. So I don't have very many patients on my panel who are overusing. I have not had anybody request buprenorphine. These were pretty surprising to me, considering the locations of these clinics being in areas with the highest rates of opioid overdose. So I think, this really showed us that these providers need education around what someone with opioid use disorder might look like, might they be expressing in their appointments, and how to identify the patients that may be in need. So unique challenges in rural Maine. We cover a pretty big area up here. Getting here is part of the problem. I have some veterans that live off the grid, so to speak, in the woods. So you know, even before social distancing was a thing, a lot of our patients were already social distancing on their own. So getting them to drive 2 to 4 hours, if they even had a car or not, pretty impossible. So making this accessible. Other ways that we overcame these barriers. So one of the strengths of this is that we really did have leadership support from the national VA level all the way down to our local facility and local clinics. So a lot of the national VA initiatives have been around opioid safety, educating veterans on opioid overdose, getting them Narcan, and also getting patients with an opioid use disorder medication to treat that. Patient interest. So when patients that were stable on buprenorphine and had been driving to Bangor weekly to monthly to get their prescription and go to the group, when they found out that this was available, were very interested in transitioning their care back to the local level to save them all that time, gas, mileage. Patients that had not yet been enrolled in the program, very eager to know that it exists and get the treatment. Another thing that was very helpful to the success of this was the development of a how-to toolkit. So our goal was to make one document that someone could go and get everything they need in one place. So it's very inclusive. It's about 70 pages long, but it does really set you up nicely if you're a site that wants to start having their patients receive buprenorphine, or if you're a prescriber looking to prescribe. Examples of things in that, the service agreements between the hub and spoke sites, home versus office induction considerations, legal resources for VA prescribers, example intake and induction notes, patient education materials, Narcan opioid overdose information. And one thing that I think is really helpful is there's also a checklist of who does what. So it really lays out the things that need to be done, and you can decide who's going to be responsible for that. So we shared that on the VA SUD SharePoint, so anyone in the VA system has access to that. And I've heard from other sites that it's been very helpful for them making similar implementation strategies at their facility. I've also embedded it in the slides today, so hopefully you'll have those electronically as well. Another thing that I think was helpful is that the power was really in the spoke sites to choose the patients they were going to refer and when. So instead of them feeling like, oh, this is something I have to do, it became more of something that they're empowered with. They're looking out for veterans that they should be referring to us and allowing them the control of that. They also had ongoing support in person, phone, and email. It was very common to hear that they feel that they have less resources available to them as providers or nurses or support staff compared to the main facility. So knowing that they had the support from the external facilitators, addiction psychiatrists, as well as a clinical pharmacist available to answer questions if they had issues with urine drug screens or questions on buprenorphine itself. Just knowing they had that support was helpful to them. I do have a chart here that shows the patient results in the initial 6 months of this year-long project. So there were 12 patients. A couple of things I want to highlight in this. So of the 12, all but one had chronic pain, so a very complex patient population between the substance use disorder, chronic pain, psychiatric comorbidities. As far as induction type, half of them were transfers who had been stable and traveling to the Bangor CBOC or the Augusta facility for care. So half of them got to transfer back to their local CBOC for care. We had 2 home inductions and then a few in-clinic inductions. So those are a little bit more of a commitment for the veteran because they had to drive to the Bangor CBOC or the Augusta facility for the in-clinic induction because we're bit more equipped to monitor them and have the space for them to be in the clinic. And then they were able to transfer their care after they did that initial induction back to their local CBOC. There is variability between the number of telehealth appointments they had with the hub psychiatrist. So depending on the intensity of what they needed is reflected in how often they're being seen by the prescriber. And then at the 6 months following the initial visit with the telebuprenorphine prescriber, 9 patients were still active. We have 1 patient that had to transfer to a higher level of care due to psychiatric instability. 1 patient couldn't tolerate buprenorphine, and 1 discontinued treatment altogether, kind of lost the follow-up. One case that I want to highlight, we had a veteran that had a suicide attempt about 2.5 hours from our Maine facility. This patient had been using 3 bags of heroin daily prior to the suicide attempt. In his chart, he was quoted as saying, "Heroin owned me." He had nothing to look forward to besides an overdose. And he had a lot of unmanaged chronic pain and financial problems leading up to a suicide attempt. Fortunately, he survived that. It was a gunshot wound. He had a surgical admission and psych consult at a community hospital. He was there for a little while, and then when he was stabilized, we worked with that community hospital to have a discharge plan for him to come directly to our main facility for buprenorphine induction. So that was a all hands on deck type case, chief of mental health involved, and we felt it would be best for that patient to be under the care at our main facility. He stayed in the area for about 2 weeks to get stabilized, and then he was able to transfer his care back to his local CBOC and engage in this tele-MOUD program. I'm happy to say he's fully engaged in care, attending psychotherapy regularly, and he's had no relapses. And so really just want to highlight how beneficial this could be to a patient who might not otherwise have access to this care. Another one that comes to mind, within the year of this pilot project, we had a veteran living in northern Maine. He moved down to southern Maine for a job, relocated to central Maine, and then back to northern Maine again. So 4 different locations, and he was able to stick with the same provider and continue his treatment without interruption by being involved in this program. As far as lessons learned, so I would recommend to have a coverage plan when your hub prescriber is off or unavailable. So make sure the local staff know, do they need to contact someone else at the hub, or are there arrangements made with staff at the other VA healthcare system. Make sure there's flexibility of prescriber, staff, and patient. So because it is telehealth, as we saw earlier, even with this conference, sometimes there's technical difficulties. So allowing some flexibility, a little extra time for the patient to be seated, meet with the nursing staff, and with the prescriber to make sure that there's adequate care for the veteran. Plan for patients that require a higher level of care. So I told you about one veteran we had to transfer out of this program, but knowing when to recognize that the telehealth modality may not be in the best interest of that patient. Include stakeholders in leadership updates and project meetings and calls. I would say that this is one area I think we could have done better in. We had weekly calls with the implementation team. So a lot of time it was me relaying information instead of hearing it directly from the CBOC staff. So I think if we did this again, we would set it up so that they're involved in the call at least monthly without making them feel like it's too big of a commitment. But hearing directly from them, I think, could be helpful. And then make sure you have sustainability when the funding runs out. So if you have like a resident run program, a temporary provider, or is like a grant funded type of project you're working on, making sure there is a plan in place to get the patient care when that changes or runs out. So current and future plans with our project, the toolkit I mentioned earlier We included a tip sheet for treating veterans in COVID-19 times, and we'll continue to update this document over time. We're actively transitioning the Maine patients to local prescribers. So we're still going to continue this hub and spoke model, but the hub is actually going to be out of our Togus location. We're in a better place now than we were a year ago to provide the medication management on a more local level. We have 2 addiction fellows, and we're actively hiring a previous addiction fellow to work more in the pain clinic and primary care role and do an opioid reassessment clinic. And we have a psychiatrist who's really been a champion for getting everything a little more standardized across the VA Maine healthcare system. And as far as extension of this grant, there's a 3-year extension, and we'll be expanding this model to additional sites, 2 in the Northeast and 1 in the South that need some additional support in getting their veterans access to tele-MOUD. I just want to acknowledge the project team listed here. And I thank you all for tuning in to listening to me, and I look forward to the discussion.
Thanks so much, Nicole. That was great. And amazing how relevant your telemedicine work in the VA is now to all of us who never had done much of that, but during COVID, you know, and treating patients and conducting research as well. So that was awesome. As a reminder to everyone, please, we're going to return and have kind of a discussion period with both of our presenters in this session at the end. So if you have some good questions for Dr. Brunet, please place them in the question and answer little box that you'll see at the bottom of your Zoom screen. And actually, Nicole, in your patient sample, I noticed it looked like a little over half of those patients also had a concurrent diagnosis of PTSD, I think, if I recall. So that's kind of a nice transition point to our final presenter in this session, who is Dr. Kelly Peck. And Dr. Peck is a clinical psychologist and colleague of mine here in the Vermont Center on Behavior and Health at UVM. His research and clinical interests have included a focus on the development and evaluation of novel treatments for treating opiate use disorder, including randomized trials evaluating interim buprenorphine dosing for reducing illicit drug use and other risks during waitlist delays. And then Kelly has also worked extensively with individuals with concurrent substance use disorders and PTSD, and especially around the delivery and evaluation of cognitive behavioral treatments for PTSD. So today in our last presentation, he's going to, in this session, share some of his ongoing work in both of those areas that I just mentioned. And Kelly's talk is entitled Innovative Interventions for Rural Adults with Opioid Use Disorder. Take it away, Kelly.
Great, thank you. Going into this week, I felt like I was pretty technologically savvy, and I'm realizing that there's some work to do there. So thank you for your patience with the technical issues I was having earlier. So as Dr. Sigmon mentioned, my name is Kelly Peck. I'm I'm at faculty here at the Vermont Center on Behavior and Health, and today I will be presenting on 2 separate projects. The overarching goal here is to talk about innovative interventions for rural adults with opioid use disorder. And I'll be talking about 2 different projects. The first having to do with an interim buprenorphine treatment trial that we're doing with individuals who are not currently in treatment for opioid use disorder. And then I'll be talking about an independent project of mine in which we are examining the efficacy of a behavioral intervention for PTSD among individuals who are already maintained on either buprenorphine or methadone. I don't have any financial disclosures or conflicts of interest to disclose. I don't think I need to tell folks who are in this meeting about the ongoing opioid epidemic, so I'll just hit some high points. In as recently as 2018, close to 10 million people reported misusing prescription opioids, and an additional 800,000 reported using heroin. Although there is some data to suggest that rates of opioid use has begun to decline, the prevalence of opioid use disorders and overdose mortality continue to increase. We know that opioid use disorder is associated with a host of adverse consequences, including infectious diseases, overdoses, as well as premature deaths. And the economic cost of opioid, the ongoing epidemic, is estimated at over $78 billion annually. And from our talks earlier today, I'm realizing that I need to update some of my language here, but opioid agonist therapy with methadone or buprenorphine is efficacious in reducing illicit opioid use, IV drug use, overdose, criminal activity, and infectious disease. However, the demand for treatment often far exceeds the available capacity in many areas of the country, particularly in rural regions. And you can see this map here to the right, just indicating counties where there's high rates of opioid overdose and low treatment capacity. So rural individuals with opioid use disorder often remain on wait lists for months and even years. And during this time, they're at high risk for continued use, as well as other adverse consequences. So innovative approaches are urgently needed to expand access to evidence-based treatment for opioid use disorder. Our group developed a novel approach. 5 or 6 years ago, people were waiting as long as 2 years to get into treatment in Vermont. And so our group developed a novel approach for bridging this gap between waitlist and more comprehensive opioid treatment here in Vermont. And so this was, we recruited individuals who were stuck on wait lists, who were attempting to get into treatment, and we were able to provide treatment for a period of 3 months. The treatment components included automated medication dispensing. So you can see this photo here on the slide. This is a MediWheel device. We were able to dispense buprenorphine with that device. And this device has all sorts of security features that would minimize non-adherence, so people could take their medications at home without having to come into the clinic every day. We did daily monitoring via an automated interactive voice response system. So they would get a phone call every evening that would assess any recent opioid use, withdrawal, and craving, and it was our way to check up on individuals in between sessions. We did random callbacks through that interactive voice response system. So they would get a phone call and they were instructed to return to the clinic to leave a urine sample, do a pill count, and then take their dose under observation. Then we also delivered some HIV and HCV hepatitis C education via iPad. So that was, this is our pilot study that we conducted a couple of years ago. It was a 12-week trial, so about 3 months. We recruited 50 individuals who were 50 adults who met criteria for opioid use disorder, who provided an opioid positive urine intake, and then were waitlisted for treatment somewhere in the community. So those 50 individuals were randomized to one of 2 groups, the treatment group being interim buprenorphine treatment. If they were randomized to that group, they visited the clinic every 2 weeks to take a dose. They provided a urine sample, and then they received the remaining doses in that MediWheel device that I showed on the previous slide. So they were able to take the majority of their doses at home. They answered those IVR, those interactive voice response calls every evening, and then they completed random visits about twice a month. And then they completed monthly follow-ups with us for 8 and 12 weeks following the intake. And then our wait list, they simply remained on wait list and then came back to the clinic to complete follow-ups every 4 weeks. So the findings of this pilot trial were published in the New England Journal of Medicine in 2016. And so our primary outcome was illicit opioid abstinence. And just to orient you to this figure, you can see on the bottom, on the x-axis, we have time, so intake for 8 and 12 weeks following intake. And then on the y-axis, we have the percent of participants who were naked or who were abstinent for illicit opioids. So you can see that participants who were randomized to the treatment group, that interim buprenorphine treatment, they achieved significantly greater rates of abstinence from illicit opioids. And whereas our waitlist group, none of them were abstinent for illicit opioids across over the course of the 12-week trial. So really nice outcomes there. You can see those rates of abstinence in our in the IBT group tailing off a little bit towards the end. We'll come back to that here in just a minute. We also saw that participants in the IBT group demonstrated greater reductions in IV opioid use. And so again, we're seeing nice reductions in IV use in the treatment group, whereas the waitlist group remaining the same across the course of 12 weeks. In terms of some, I don't know if I want to call them unanticipated benefits of the treatment, but some secondary outcomes. We saw participants who presented at intake, our participants presented with elevated rates of depression as measured by the Beck Depression Inventory. And what you can see here, our solid line is our interim buprenorphine treatment participants, and then the dashed line is our waitlist group. And what you see is that the waitlist group showed no changes in the depressive symptoms, whereas depressive symptoms decreased significantly among our interim buprenorphine treatment participants, even though they didn't receive any formal counseling. We also, as I mentioned at the beginning, delivered some HIV and hepatitis C an educational intervention. And so we saw that participants who received the educational intervention showed significant improvements in their HIV and HCV knowledge, and that these improvements persisted over the course of the 12-week study without any additional educational sessions. So currently, we're in the midst of a larger scale trial in which we're trying to expand upon this pilot study in several key ways. So we've increased the duration of treatment from 3 to 6 months to see if those outcomes are sustained over a longer period of time. We're also working to deliver this intervention to individuals who are living in rural areas, medically underserved geographic regions around Burlington. And then we've also incorporated a new component that addresses opioid overdose risk. Very quickly, that opioid overdose education intervention consists of a pre-assessment of our participants' knowledge about overdose. We then deliver an interactive, we have an application on our that we can deliver via iPad, an educational intervention about opioids and opioid overdose. We also provide some information about how to administer Narcan. Everybody who's enrolled in this study receives Narcan. And then following this educational assessment, we assess their knowledge of opioid overdose over the course of the study. So I'll present the findings of our ongoing trial. So the text might be a little bit small here, but our participants, we've enrolled 76 participants, 38 to the treatment group, 38 in the waitlist control arm. Our participants showed no significant differences in terms of demographic and drug use characteristics, with the exception of employment. Our IBT participants were a bit more likely to be employed full-time. In terms of our primary outcome, this is looking really good so far. This is kind of a preliminary look at the data. But our individuals there with the black dots, those are individuals who have been randomized to the interim buprenorphine treatment trial. Again, the x-axis is time or study week. And so you can see that individuals who received the intervention reported significantly greater rates of illicit opioid abstinence compared to the waitlist group, such that those who were receiving the interim buprenorphine treatment intervention, at least 84% of those individuals were negative or illicit opioid abstinent at each of those subsequent time points following intake. You do see a little bit of an increase in illicit opioid abstinence in our waitlist group over time, and that just is an indicator that those folks who are waitlisted are getting access to treatment. Nonetheless, those two groups are significantly different at each of those time points. Our HIV educational intervention, as part of that, our participants answer 50 questions about their general knowledge of HIV, sexual risk behaviors, and drug risk behaviors. At intake, participants answered an average of 61% of items correctly. They then took that HIV knowledge or educational intervention, and then following the intervention, this brief educational intervention, they answered almost 80% of items correctly. And so there's a significant difference attributable to that educational intervention. And that knowledge that they acquired was sustained over the course of the study, such that without the addition of any additional education. We see a similar story with our hepatitis C knowledge. They answered 17 questions about hepatitis C. At intake, on average, our participants answered 56% of these items correctly. They took the brief educational intervention, and then following that intervention, they answered 81% of those items correctly. And that acquired knowledge actually was further improved over the course of the study, and participants answered at least 73% of those items correctly over the course of our 24-week trial. And then in terms of our new opioid overdose knowledge intervention, participants answered 12 questions about opioids generally, opioid overdose, and how to respond in the event of an opioid overdose. They demonstrated pretty good knowledge at baseline. 75% of items were answered correctly prior to the educational intervention, but then following the delivery of that intervention on iPad, our participants were answering 92% of items correctly, and that knowledge was sustained over the course of the 24-week trial. So it seems like these educational interventions are doing what they're designed to do. In terms of psychiatric symptoms, participants who are randomized to that IBT or interim buprenorphine treatment group, they're reporting significantly lower levels of depression compared to our waitlist participants. And so these asterisks indicate significant differences between groups. So we can see that our treatment group is reporting lower rates of depressive symptoms at 4, 8, 12, 20, and 24 weeks post-randomization. We see a similar story when we look at symptoms of anxiety. So our participants who are randomized to the treatment group are reporting significantly lower levels of anxiety compared to our waitlist participants, such that there are significant differences at 4, 8, 12, and 20 weeks post-randomization. So we're very pleased with how this data is looking currently. So thus far, in our efforts to replicate and further build upon the results of our pilot trial, we're observing similarly high levels of illicit opioid abstinence that are generally sustained over this longer 6-month period. We're also observing significant increases in HIV, hepatitis C, and opioid overdose knowledge, as well as decreases in depression and anxiety symptoms that are sustained over the 6-week or the 6-month trial. So I'll transition here to the second study that I told you I would talk about. And in this study, we are examining a behavioral intervention for PTSD among individuals who are maintained on either buprenorphine or methadone. We know, we've heard a lot of talks just in the past 2 days, really providing some nice evidence that methadone and buprenorphine are the most efficacious treatments for opioid use disorder. There's not much question about that. However, psychiatric comorbidities are prevalent among individuals with opioid use disorder. We know, depending on the study that you look at, you see that almost all individuals with PTSD report, or all individuals with opioid use disorder report some sort of lifetime trauma exposure. About 90% of folks with opioid use disorder are reporting that they've experienced a traumatic event in their lifetime. Compare that with about 60% in the general population. You also see high rates of PTSD. About a third of folks with opioid use disorder would meet criteria for PTSD versus about 7% within the general population. So for those of you who are unfamiliar, PTSD is defined as a psychiatric disorder that occurs in people who have experienced or witnessed a traumatic event. That traumatic event could be a natural disaster, the experience of sexual violence, physical assault. It could be any number of events. But in addition to experiencing a traumatic event, to meet criteria for PTSD, these individuals also have to exhibit symptoms from each of these following 4 symptom clusters. So an individual would need to demonstrate intrusion symptoms, so intrusive thoughts or nightmares, avoidance of internal or external stimuli that are associated with the trauma. There's also negative alterations in cognition and mood, and arousal and reactivity, so that could be hypervigilance, irritability, trouble sleeping, things like that. And so we know there's also an emerging body of evidence that indicates individuals with PTSD who are being maintained on either buprenorphine or methadone tend to experience worse outcomes. Even if they're maintained on these medications, they may continue to experience psychiatric distress. They're more likely to drop out of treatment and also more likely to relapse to illicit opioid use. The good news is that prolonged exposure therapy is an empirically supported, efficacious intervention that's really regarded as a first-line cognitive behavioral treatment for PTSD that's demonstrated efficacy both in the general population as well as with veterans. Recent studies suggest that prolonged exposure therapy is associated with reductions in PTSD symptom severity in patients who are receiving treatment for, who are receiving concurrent treatment for opioid use disorder. So if you combine these two interventions together, you tend to see reductions in PTSD symptom severity. As with many behavioral interventions, attendance is a problem. People don't come, they don't attend sessions, and they don't get a full dose of treatment. And this is particularly relevant because, I guess as a side note, we see that opioid agonists such as buprenorphine and methadone are associated with significant reductions in psychiatric symptoms. And so when you consider all of this evidence together, there's not a previous study in which individuals, so none of these studies examining prolonged exposure therapy have included a control group in which individuals only received treatment for opioid use disorder, like buprenorphine or methadone. So to this point, it's unclear whether these observed reductions in PTSD symptom severity that are attributed to prolonged exposure therapy, are they actually due to the behavioral therapy, or are they a function of being maintained on buprenorphine or methadone? So I'm attempting to answer that question. So currently, we are conducting a 12-week randomized trial to evaluate the effects of prolonged exposure therapy above and beyond what you see with opioid agonist treatment for reducing PTSD symptoms among patients who are currently, who meet criteria for concurrent PTSD and opioid use disorder. So we're recruiting adults who have been maintained on methadone or buprenorphine for at least a month, who also meet criteria for PTSD, and we're randomizing them to 1 of 3 groups for the duration of this 12-week trial. So in our first group, these individuals will just continue to receive buprenorphine or methadone from their current provider. They'll come back to our office once a month, complete some questionnaires. The second group, you can see how these groups build on each other. The second group continue to receive medications, buprenorphine or methadone, from their current provider, the complete follow-ups, but they'll also have access to meet with a therapist to do 12 60-minute sessions of prolonged exposure therapy. And for those of you who are unfamiliar with prolonged exposure therapy, the idea here is that a core symptom of PTSD is avoidance. And so one of the ways that we attempt to change that pattern is we use exposure exercises. And so the idea is in therapy with your therapist, going through a detailed narrative of your trauma. So rather than avoiding those thoughts and memories and emotions, you're approaching them, you're talking about them in a great amount of detail, and then working with your therapist outside of session to do in vivo or real life exposures. And that is identifying safe and gradual ways to find things out in your environment, in your real world, that are associated with your trauma, and approaching those things, interacting with those things rather than avoiding them. So those are the first 2 groups. And the third group, again, each group builds on each other. They continue to receive buprenorphine or methadone from their current provider. They complete follow-ups. They have access to a therapist to do 12 sessions of prolonged exposure therapy. But these individuals will receive monetary incentives contingent on completion of these therapy sessions. So here at VCBH, we have a long history of implementing contingency management protocols to incentivize cocaine abstinence. We've also used similar programs among individuals who are smokers and individuals with opioid use disorder. And so this is just a quick snapshot of our incentive program for those individuals in our incentivized prolonged exposure therapy group. So for their first session that they attend, that would be worth $20. And then with each consecutive session that they attend, that incentive amount increases by $5. So their first session would be worth $20, their second would be worth $25, the third would be $30, so on and so forth. We've also incorporated some strategically placed bonuses and our goal here is to incentivize consistent attendance versus sporadic attendance. And so for every 2 consecutive sessions a participant attends, they would receive a $50 bonus. And then if somebody was able to attend all 12 sessions, they would receive a $100 bonus at the end. So altogether, a participant in this group could earn $920 if they attended all 12 of their therapy sessions. Obviously, if somebody missed a session, they would not be incentivized for that, and their incentive amount would reset back to $20. But if they attended 2 consecutive sessions, then their voucher amount would reset to where they were before that missed session. So we really strategically designed this program to incentivize consistent attendance to these therapy sessions. The idea being that if people attend more sessions, they'll show greater improvements in their PTSD symptom severity. So we have enrolled 18 folks in the study to date. In fact, that's up to 19 because I met with somebody this morning. But for our 18 folks who are enrolled, these individuals are about 37, 38 years of age on average, primarily female, exclusively white to this point. Very few of these folks are enrolled full-time. They've been using illicit opioids, or they used illicit opioids about 7 to 8 years on average, and have been maintained on methadone or buprenorphine for about 5 years. So these folks are pretty stable on their medications. In these individuals, we're seeing high rates of sexual assault as well as physical assault. So you can see these breakdowns of these index traumas that people are reporting. And on average, folks are reporting moderate to severe PTSD symptom severity on average. We're seeing high rates of concurrent anxiety disorders, as well as about a quarter of our folks are reporting major depressive disorder. So far, we have really nice evidence to indicate that our incentive program is working. So on the bottom, we see our PET group, which is non-incentivized, versus our PET plus group, which is receiving those incentives for every session that they attend. So our folks who are receiving incentives are attending 83% of their therapy sessions, which I am thrilled about. In our non-incentivized group, these individuals are only attending about 16% of their sessions. So there's a stark, it passes the eyeball test. There's a stark difference between these groups in terms of attendance. We're pleased with our attendance and retention rates thus far, although there is some variation between the groups. People continue to come to those follow-up sessions. They're incentivized regardless of what group they're enrolled in. They receive $50 every time they complete those follow-up sessions, and people are coming to those appointments. So we've been happy with that as well. In terms of our primary outcome, which is PTSD symptom severity, it's measured with what is widely considered the gold standard in terms of assessing PTSD. That's the clinician-administered PTSD scale. So that's the CAPS-5. It's based on DSM-5 criteria. And so you can see that all 3 groups are showing reductions in clinically significant reductions in their PTSD symptom severity. So this is very preliminary data. These groups are still kind of hanging together. So we're excited to see what unfolds over the next couple of weeks and months. We are happy to see that those folks who are getting therapy are showing nice reductions in their PTSD symptom severity. But given that these groups are kind of clustered together, I did, for this presentation, want to look and see, like, what does this look like on the individual level? And so if you look at our OAT group is just continuing to receive their buprenorphine or methadone from their current provider, and then our non-incentivized prolonged exposure therapy group, you can see that if we look at individual scores, they're all over the place. There's not a real consistent story that's coming out just yet. But then if you look, and this is the slide that gives me a lot of optimism about what we're doing, if you look at our incentivized group, you're seeing a really consistent pattern of these nice gradual reductions in PTSD symptom severity over time. And so that gives me a lot of optimism about what we're doing, particularly so early on in the study when these 3 groups are really hanging together in terms of this primary outcome. And then just as a secondary outcome measure, we're also administering the PCL-5, which is a self-report measure of PTSD symptom severity. We're seeing kind of a similar story here, in that all 3 groups are showing some, we're seeing some nice reductions in PTSD symptom severity, more so for our incentivized group, and actually our group is just maintained on their current medications. But these groups are really hanging together still. We're excited about continuing to collect more data to see how this story plays out over time. In summary, our preliminary data indicates that individuals with concurrent opioid use disorder and PTSD are much more likely to attend therapy sessions if they're incentivized to do so. Individuals who are randomized to that incentivized group are reporting clinically meaningful reductions in their PTSD symptoms. I don't want to use the word significant because it's so early on that we haven't really done any significance testing. And then we also know that prolonged exposure therapy so far is not associated with increases in illicit opioid use. And then our individuals in that incentivized PTSD group, well, let me take a step back. So our folks in our two control groups, the non-incentivized prolonged exposure therapy and those who are continuing to be maintained on their medications that they came in with, they're also showing significant reductions in PTSD symptoms, even though they're receiving little in the way of PTSD-focused treatment. So our continued work is aimed at understanding why this might be the case. Why are we seeing reductions in these groups as well? So altogether, kind of taking these two studies and providing some conclusions, big picture view. Innovative approaches to treatment, such as low barrier technology-assisted buprenorphine dosing, like we're doing with the interim buprenorphine treatment trial, can be useful for promoting illicit opioid or promoting illicit opioid abstinence, that's not right, in rural settings. Individuals with concurrent opioid use disorder and PTSD are at risk for worse outcomes, including continued psychiatric distress, dropout from treatment, and continued illicit opioid use. And data from an ongoing randomized pilot trial that I've just presented supports previous studies indicating that prolonged exposure therapy is associated with reductions in PTSD symptoms, and it's not associated with increases in illicit opioid use. The use of incentives appears to be helpful for increasing attendance to this efficacious but poorly attended intervention, but we still need to conduct more work in order to determine whether or not prolonged exposure therapy is associated with these reductions in PTSD symptoms above and beyond what you would see if you just maintain somebody on buprenorphine or methadone alone. I want to thank everybody who's been associated with this study. I want to thank my mentors, Dr. Sigmon, Higgins, and Phil Adis. And then I also want to thank our treatment teams, both on the IBT study as well as our prolonged exposure therapy study team. Without their help, there's no way that this work would get done. So I want to give credit where credit is due. And so at this point, I'll take questions. Thank you for your patience with me today. And it's a pleasure to be here.
Thanks, Kelly. So thanks for the great presentation and the really nice data. And let's see, as we wind down this session number 2, and start to turn our thoughts to the discussion period with our panelists. First, I just want to remind or ask everyone, any questions for either of our presenters? So Dr. Brunet or Dr. Peck, please go ahead and plop them in the Q&A box that you see at the bottom. And, oh, and I'll also let me ask both of our presenters to, if you haven't already, turn on your video and unmute yourselves if you can. And I think we have, looks like about a little less than 15 minutes remaining in this session. I think we disband at 12:05 for this. So that's pretty good. And we have some questions coming in. First one maybe to Nicole, wondering about the Telebut platform being used in the VA setting. If you have any thoughts on what might be some of the most important elements to it to support its use or generality to other like other settings and populations outside of the VA healthcare setting? Like what elements do you really think are critical for broader generality?
Yeah, that's a great question. And we really hoped doing our project within the VA that it would be generalizable to places outside the VA and using things like that toolkit to get you started. But what I would say most important is making sure you have your telehealth infrastructure figured out. Having a telehealth coordinator who can work with your hub sites and your spoke site is very important. Having one person in that position to kind of arrange that. The leadership support, of course, is going to be very helpful in pushing your ideas along. So making sure you have that from a facility level down to your local level, get into those clinics or those remote locations and talk to the people on site, find out what they need, what are they seeing that would be most beneficial to them. So the telehealth, leadership support, flexibility in your way that you're going to handle these patients, having backup plans if something does fail, how can you get them this care? And I would say too, one thing that we learned, not just within the VA, that I think is pretty generalizable, is making it available and accessible so that you can reach those patients pretty quickly when they show up, and you have somebody on that other end to see that patient if they present right then and there.
Yeah, that's a good point. Immediacy is so important in all of our different clinical and research settings, we found. So that's helpful. Let me see. Kelly, a question has come in for you about the interim bupe project that you presented. Let's see, were all of your participants aiming to transition to hub type settings? So if so, do you feel that kind of this interim dosing approach could help transition patients directly into a spoke or primary care practice, maybe giving them a bridge for practices that are not able to provide induction, I guess like immediate induction in the outpatient clinical setting? Do you have thoughts on that?
Yeah, and so that was exactly the reason that the pilot trial was initially conducted. So a couple years ago in Vermont, there were really long wait lists to get into treatment, and the whole goal was to help folks transition into that more comprehensive treatment. And so that's what we continue to try to do. People who participate in our studies, our aim is always to help them transition into a hub or a primary care practice where they can continue with treatment following the end of our study.
And I will say from the work we're doing here that Kelly's describing, it's pretty common that when we're working to advocate for our participants in the interim bupe studies, and we're reaching out with their consent to community providers to potentially transition them to office-based bupe setting after the study, the providers do seem to be quite receptive whenever we can say that we've already done the induction and the stabilization that sometimes can be dicey, and they don't have to worry about precipitating withdrawal, or we already have some evidence of clinical stability and such. So, but I'd never really thought too much about maybe an intentional, kind of 1-2 punch of it preceding treatment. More generally. Another question coming up here for Nicole from Betsy Richard. Will there be telehealth in the part-time clinics such as Bingham? So that may be a Maine, is that maybe a Maine specific question, but is that something?
That's one of our part-time CBOC. So I'm not entirely sure what we offer now for telehealth there, if anything. We chose the 3 locations that we did for this pilot project, but like I mentioned, we have a psychiatrist champion now who's really trying to standardize the process across the whole VA Maine system. So I think we'll see more standardization there. So if a veteran presented in Bingham and needed buprenorphine, they would get it just as if the patient presented at Bangor or Augusta. So more to come with that. And I will say, with the COVID-19 pandemic, it's actually favored getting this teleprescribing, and you can do it over the phone now. We can use what's called VA Video Connect, where the veteran can physically be in their home. So definitely more modalities available. And if if you do know a veteran in the Bingham area, you can certainly reach out to me and I can get some coordination about who to contact for that.
That's helpful. And Nicole, something you just said reminded me early on in your talk, you mentioned a voucher program for short-term prescriptions.
Yeah.
Can you just expound on that? We only have a few more minutes, but briefly on what you were referring to. And was that buprenorphine? We're doing a little bit of, like here when patients present at the ED, I believe with overdose, they, in a pilot project can be giving a short-term script, like 3 days of Suboxone or something, and then case management to help them enroll and treatment follow-up. But was that kind of a similar thing, or were you talking about other medications for short-term voucher?
So it's pretty much any medication. We really need it in this state because our pharmacy is only physically located in Augusta. So that allows the veteran, it's a voucher, it has their patient information on it, the prescriber information, the medication. They can bring it to any community pharmacy in Maine that participates in the program, which is essentially all of the community pharmacies. And then they can get up to a 7-day supply of that medication and they don't have to pay for it. So they get the medication right then and there. Helps with things like snowstorms and delays in their packages of the medication. We actually had an uptick in the nationwide voucher use when the COVID pandemic really caused delays in the postal service delivering. So we've actually relied on it pretty heavily. It is nice because the patient doesn't have to worry about paying out of pocket up front and getting reimbursed. It's all taken care of through the VA.
Yeah, that's great. Do you think there's potential for other, for adoption of that more in non-VA settings too, do you think? Or is it pretty unique to like having, you know, that?
Yeah, I honestly can't say because I know even amongst the VAs, not every VA has that program. It might have to do with rurality and their ability to get to the pharmacy and whatnot. So I can't really comment on that, but it has been very helpful in Maine.
Well, that's really interesting. Let's see. So we're winding down. I did get a question, Kelly, for you in terms of just the mechanics of the waitlist comparison group. So how were you able to maintain participation of waitlist, the control condition folks in the study without treatment, which we know can be very hard?
Yeah, so starting with the pilot trial and continuing today, for our waitlist participants, you know, this was particularly effective back a couple of years ago when there was less available in the community, but we do offer the option to cross over. So if they come to their follow-up appointments over that 6 month, or now it's a 6 month period, before it was a 3 month period, if they come to those follow-up appointments at the end of that waitlist period, we're then able to cross them over and provide the interim buprenorphine treatment protocol to them at the end of that period. And then the goal would be the same, to then help them transition into a practice in the community.
And then also, I guess we should point out that there's, of course, monetary compensation for completing.
Right.
I don't know, is it maybe a
Right.
2 or 3 hour visit? The monthly follow-up assessments take some time. So
it's even less than that, yeah.
Okay, so we provide that. And then we're also giving Narcan, fentanyl test strips, community resources, helping. So even though folks randomized to the control condition, we offer to help them contact other, you know, providers. And that's why you see, you get, you know, the rates of abstinence in the control group, because they were not randomized originally to receive it at the UVM study, nothing prevents them from going out. And it's just more available in Vermont than it was during our first trial. But so we also often help, it doesn't help the data, but it helps them to connect them with rural providers. All right, well, that does it. I think I've gone through most of the questions. This has been a great session. I really would like to thank Nicole for pulling it together, and Steve for the overall leadership, and definitely Kelly and Nicole Nicole Tuig for our administrative support, and Nicole Brunet for your presentation. And thanks everyone else for joining us, and hope to see you back after lunch for our next sessions. Thanks, everybody.
Thank you.